Yeah. Yeah. Good evening, everybody, and I'm so sorry for the delay. We were waiting for our experts, and it is almost 3 weeks since we had last MDM. Due to some unavoidable circumstances, we could not have the meeting which was planned on 6th, and today it is 27 September MDM, and from now onwards we'll continue our previous pattern of two weeks gap. We have got 4 cases today, and without further delay, I would just dive into the cases. Let me share my screen. Sorry, today's experts, we have got Dr. Vimal Raj as a radiologist expert, Mithun as our pathologist expert, Ritu madam as Mithun as a rheumatologist expert, and Ritu madam as a pathologist expert, and our all-time favorites, Rajan sir and Murli Mohan sir, who will be joining in a while. Myself will be presenting my case and Shobha madam's case also, because she is in Delhi and she could not present. However, she has prepared her case and we are grateful that she provided. There will be one case from KIMS Trivandrum by Dr. Sneha, and Rajan sir has got one case. So we have 4 cases, and I will just share my screen. So this is case 1. Vimal Raj sir, case 1, Mr. S. So this is 36 years old man who is hailing from Delhi, and his occupation is he's a marine engineer, he's diabetic, and it is controlled diabetes. It is not uncontrolled diabetes. First time he presented to a Mumbai clinicians with a cough with mild hemoptysis, low grade, evening rise of temperature, loss of weight and loss of appetite of 10 kilogram in 5 months. Initial CT scan, which I think we will go through all the CT scans one together once I finish this history, was first CT scan was taken in June, which was right lower lobe consolidation and right sided pleural effusion. His sputum net was CB net was negative, but he was empirically initiated on TB medicine in July. Now, because he didn't have any improvement in his symptoms, bronchoscopy was done somewhere in August 2024, which was also negative, but Enterobacteriaceae complex was detected. He was given 10 days of strong antibiotics. And the treating doctor felt that there is a resolution in the CT scan images, so he stopped TB medicines, and a patient was off TB medicine somewhere in August. Now that antibiotic which was given was meropenem, and on the end of treatment, he was again one CT scan was taken, and then that time this patient also changed many doctors, so he went to another doctor this time, and that doctor found that not only right side, now there is bilateral pleural effusion, and he decided that it is a right thing to continue TB medicines, so he continued TB medicines. And then finally he felt that he's not getting correct answer what is going on, so he came to me. Now, when I examined him, he was stable, clinically stable. There was nothing significant which I could find out other than diminished breath sounds. His ESR was 84 and he had thrombocytosis with platelets of 418. 1 second. I'm sorry, it was Murli Mohan sir and I had to take it. So I think Vimal Raj sir, you can go ahead with CT scan. I feel otherwise it won't make sense is what we are talking about. So here is a gentleman who had May problem of loss of weight, loss of appetite, and then started on empirical ATT, which was stopped and then restarted. And he has some 3 CT scan or 4 CT scan in a timeline. Yeah.
Okay, so thank you very much. I'm just putting these cases together. Just give me 1 second. Okay, perfect. Share my screen.
Yeah, it's
Okay,
visible now.
so
Yeah.
you can see my screen. So let me start off with, we've got three scans. One is from June, July, and August of this month. So I'm going to start off from the June CT scan. I'm going to start with the lung windows to begin with, just to give you an overview of what is happening. And you can start seeing in this, the upper lobes are almost relatively normal. And as we come down, there is all these areas of consolidation in the right lower lobe. There is interlobular septal thickening, like a congestion that we can see in the right lower lobe, with a small right-sided pleural effusion. There is not much in terms of the left lung involvement. If you just closely look, there are some nodularity along the fissures. If you see across here, these fissures are
Yeah.
slightly nodular, getting small nodules across both the fissures. Now, if we just fast forward it and then see what happens to this in the month of, this is the month of July. So a month later, this consolidation is getting much more organized, getting a little bit more solidified in there. And finally, in the month of September, what we can see is again those periphyseal lymph nodes. Multiple newer areas have also started to come in there, these nodular changes, newer areas combining together, while a lot of it has got better. A lot of the consolidation has got better. And now we also have left-sided pleural effusion. If you look at the mediastinal window, and this is going back to the initial one, what you can see here are these lymph nodes. There are multiple lymph nodes, bilateral hilar lymph nodes as well. You can see that these are chunky lymph nodes. There is no calcification, no convincing cavitation in these lymph nodes. Some of these are merging with each other like a coalescing lymph nodes, but otherwise nothing much to differentiate. The other studies are all non-contrast based studies. And in here, these lymph nodes, this is the most recent one.
Yeah.
The lymph nodes seem to be still present. Nothing grossly changed, but lack of contrast makes it very hard for us. So in summary, we've got a person who has got predominantly a single lobe disease with multifocal areas of consolidation and these interlobular septal thickening, something like a lymphangitis, but not a true lymphangitis, more of pulmonary congestion in there. So unfortunately, I'm not going to be very helpful in this case. I think, Ashmita, I think the differential diagnosis remains between a sarcoid and TB. And I don't think there is very easy for us to differentiate
Yeah.
between these two. The location is very atypical for TB. It's not in the superior segment of the right lower lobe, but also it's very unusual for unilateral occurrence of sarcoid in that matter. So granulomatous infection, I would not be able to differentiate it further.
Yes. So, yeah, I totally agree that it was not a clear-cut case, because that is why he was changing doctors, I believe, because nobody was able to satisfy his queries. I did EBUS TBNA because I agree with sir that even in the last CT scan report, they predominantly mentioned right hilar lymph node is significantly enlarged. And this is EBUS TBNA. Ritu madam, would you like to say something?
Yeah, so the histopathology of this EVAS TBNA is very distinctive. There are well-formed epithelioid cell granulomas, which you can see at this image. And so there are two of them. They're non-caseating. I'd like to see the next slide.
Yeah, and
They,
then I did biopsy also from right lower lobe, right lower lobe. Yeah.
right. Right. So the biopsy actually is not giving us much of a direction, but I think the FNAC which is there is pretty clear cut. In the biopsy, what we can see on high power, I think it's in the next thing, is the hemosiderin-laden macrophages which are there.
Yeah.
And that is something which we'll have to rule out and see what is the cause. Did this patient have any bleeding? Or was it
He
secondary to
presented
infection?
with hemoptysis. I discussed with my pathologist, what do you make out of it? So she told the only thing she can make out is hemorrhage. maybe old or new, she cannot say.
I cannot say. Yeah, and whether they are heart failure cells or whether they are just primary lung in origin, because of, I believe that the patient had some infections or post-infections. If there is a bleed, one thing which I think I saw on the previous slide, which was some amount of vasculitis. If you can go
Okay,
back to the previous slide, yes.
sure.
Um,
Which
no,
one,
even
ma'am?
prior to yes. So yeah, yeah. The next one, the next one to this. Yeah. So the vessel here on the bottom corner, which is there, that vessel is showing some amount of vascular hypertrophy, and it is infiltrated with some inflammatory cells, which at this power I cannot discern whether they are neutrophils or lymphocytes. But definitely there is some amount of vascular, grade 1 or grade 2 changes. I would like to put it here in this one single vessel, not in this one, the previous one, the single vessel which can be seen. So maybe if that is leading to the hemorrhage, that has to be ruled out.
Sure.
This vessel, yes, yeah. So
Yeah,
that is, but granulomas are distinctly seen on the FNAC. So we non-caseating epithelioid granulomas, which are there.
yeah. I
Mm.
believe it was 10R lymph node. Yeah. And yeah, that is it. So my treatment was ATT was continued. The reason I have put it for the discussion is, yeah, I didn't do his anti-PR, anti-PR3 I did was negative. ANA profile was negative. Other ANA myositis panel I didn't send because I didn't feel it was looking like that. And the questions to the panel is like this: is it sarcoid or TB? His manto was negative, or is it dual pathology because we are in India, like TB causing sarcoid? And should I continue TB medicine, which I will anyway do because he has already finished 2 or 3 months interrupted TB medicine. There is no point of discontinuing it right now. But do I need to start any treatment for sarcoidosis? Yeah, I can see Sajal, please.
Ma'am, if I comment on the radiology, the periphyseal nodules
Yeah, there
are
was.
very much consistent with sarcoid. They will be uncommon with tuberculosis.
Yeah.
The nodes are symmetrical. They are not typically big like we see in garden variety of sarcoid.
Okay.
We encounter a lot of lower lobe consolidation, OP-like consolidation with sarcoid. But even with TB, we have seen consolidation even with reverse halo sign like this. So it is all these things. None of them are characteristic or pathognomonic of one of the disorders, but when put together with a negative MANTO and the non-response to ATT, I would say that this goes more in favor of sarcoidosis. So, how long has the patient received ATT? In the past, also, I think that the patient received ATT, right?
Yeah, yeah. He almost took it for 2 3 weeks. Started in June and stopped somewhere in August, first week or something. And then this time he is taking only for 2 weeks or 3 weeks. In between, he was on antibiotics. So I have presently continued TB medicine, but I have a same impression that I am dealing more like sarcoid rather than TB. Presently, also whatever investigation, CB net and everything which I sent turned out to be negative.
In the
Yes.
past, did he receive a full course of ATT anytime? Like
Never,
in the past
never.
2 year
This
period?
is this is this is
No.
first time. This is me.
Yeah. So it is not essential that we continue with ATT if we believe that it is not TB.
You
We
feel
need to
you
look
feel
at
I
other
should stop ATT.
we need to look at other organs where sarcoid may be causing involvement or damage. For example, looking at the 24 hours during calcium along with creatinine. If there's any hypercalcemia, calciuria, iron involvement.
Calcium was
So
9 point something. ACE level was 54 or something. ACE I checked and calcium was 9.
urine 24 hours urine calcium creatinine.
Okay, I will do that.
So hypercalciuria
Sure.
and eye examination slit lamp.
Okay.
So is the patient symptomatic right now?
When he came to me, he had persistent evening rise of temperature, persistent hemoptysis, and loss of appetite. So he just left for Mumbai, and I told him that he can come back to me after 2 months or something. That is when I have told that I will discuss and we will get back to you. So this is on ATT, he somehow improved. That's what I feel. I didn't give antibiotics after bronchoscopy. 1 week or 2 weeks, he came back and he is telling that his hemoptysis subsided, his fever has gone, and he is okay. His weight gain has not started yet.
So hemoptysis is a bit atypical if it is
Sarcoidosis.
sarcoid. So sometimes these cases are really difficult to differentiate. But in the current scenario, in the current case, I would say that we can continue ATT and not start steroids because there doesn't seem to be any indication for starting steroids, even if it is sarcoid.
Yeah, yes.
So
Don't you
the
think,
best
one
way
more
will be,
question, don't you think effusion is also very atypical of sarcoid? Very rarely it happens in sarcoid,
but I
isn't
think
it?
it was a very small effusion,
Very
right?
small, very small.
So
Yeah,
that can occur with sarcoid.
sure.
Small effusions can occur. 5%
Okay,
of sarcoid patients may have effusions.
sure.
How much weight has he gained on AKT, Asmita?
No weight gain, nothing.
So
Just
what has improved? Then what has improved?
his evening rise of temperature went and his
Okay.
hemoptysis subsided. And that is like hardly 2-3. He is one skeptical person who because he changed so many doctors. I think it was very difficult for me to convince him, but he agreed that steroids we will not start right away. Those things I also felt that even if it is sarcoid, I can wait and observe how TB may, because I don't want to give blanket treatment, but I wanted to find out what is it.
Ma'am, one doubt. Is there any proteinuria in proteinuria?
I'm not sure whether I check urine routine micro. I will see. I'll check
See,
for it.
in this case, no, there is a definite vasculitis in a biopsy. Systemic
Okay.
symptoms, thrombocytosis, very high inflammatory markers.
Sure.
I would put one DD should be a systemic vasculitis also.
Sure.
But
Okay.
usually, lymphadenopathy is rare in granulomatous polyangiitis.
Yeah.
But EGPA can have, but there should be eosinophilia.
Sure. But I didn't check Sianka, Pianka. I directly checked. We discussed in one meeting that PR3.
But in 50% only EGPA will be
EGPA,
positive.
it will be positive. Correct.
But otherwise, TB with vasculitis.
Sure.
And the cultures, bronchoscopic AFB cultures are negative, Asmita.
Till now.
6 weeks. How many weeks is that?
Hardly 2 weeks. I did biopsy last week. Yeah.
Okay, so we'll wait for that. Yeah, I'd continue the AKT at least till the cultures come in negative,
Sure,
but
sir.
I'm not convinced like Sejal that this is TB.
Yeah, I
Moving on,
think
sir.
everything favors sarcoid or a systemic vasculitis.
Okay.
I think we have enough. Any blood in the urine also, because that would be even more in favor of systemic vasculitis.
Sure.
Of course, the caveat is that sarcoid, TB, all of them can cause vasculitis also. So you're still stuck a bit. Have we done a quantiferon TB gold, one of the IGRAs?
I don't do it routinely, but I won't say I will do it because somehow I have lost trust in that particular test.
No,
But
a negative
Yeah.
IGRA would help you rule out TB
Okay.
probably, Asmita. That's
because
Even if it
Mando was
doesn't do-
negative now, that is why I didn't do. But okay, if you insist.
I feel it
So
is
vasculitis-
hardly useful in this kind of.
quantiferon TB gold to start with. And I think, as everyone has said, continuing the anti-tuberculosis treatment makes sense. And then we'll see.
Yeah. Yeah, I didn't want to start steroids right away, and we will see. I think let us wait for 2 months and see, because he has fleeting shadows and it might come back. And as Sajal said, that's organizing pneumonia also can be one of the feature of sarcoid, though very rare. Shall we move on to next case?
One more suggestion. One of the things to consider is a PET scan to look for
I
evidence
know.
of sarcoid in other areas.
Yes. I agree. So no more CT scan, simple CT scan. I told him to come back to me for CT scan. That I have told that don't get any more CT scan anywhere. And if CT is required or not, I will decide. Okay. We'll move on to the next case. Case number 2 is Arjun and Sneha. Are you there? Hello, Sneha?
Yes, ma'am.
Yeah, just go ahead.
Hello. Can you hear
Yeah.
me, ma'am?
Yeah, yes. We can hear you.
Good evening, all. Moving on to the second case. Today, I'm presenting the case of 51-year-old lady. She is a government office employee and it's a known case of asthma on metered dose inhalers. And as you rhinitis, dyslipidemia, and hypothyroidism. And she was under regular follow-up for asthma and was well controlled. In July 6, 2024, she presented to the emergency department with complaints of fever for 1 day, which was high grade in nature. And she had associated myalgia and headache. And there was no associated breathing difficulty or wheezes. And she was admitted as a case of influenza-like illness in room. And she was started on caposaltamivir 75 mg BD. On the very next day, she developed sudden onset breathing difficulty and hypoxemia, and she had persistent high-grade fever spikes, and her room air saturation has dropped up to 78%. She was initiated on O2 supplementation, initially via nasal drops, but had worsening O2 requirement, hence she was initiated on high flow nasal cannula and was shifted to MDICU for further care and close monitoring. On clinical examination, she was tachypnic, and the pulse rate was 105 per minute, and the saturation was 97%, with HFNC 70% FiO2 and flow 50 liters per minute. PP was 1 tons per 60 millimeter mercury, and on auscultation, there were bilateral fractures all over the length fields. Other system examination were within normal limits. And comparing the chest X-ray taken on 6 July, that is the day of admission, the repeat chest X-ray on 7 July had significant radiological worsening.
Yeah.
Ma'am, can you please?
I changed the slide.
Ma'am, can you please put this?
What happened? This is
Ma'am, what about the chest X-rays?
yeah.
Okay, ma'am.
I will just tell
May
the
I continue with the
positive
slide?
findings, Neha. We do not have time to go through each and every investigation, so I request you to just stick to the positive and relevant things.
Okay, ma'am. She was evaluated for dengue, scrub typhus, and all the malaria and mycoplasma legionella and CMV PCR tests, which were all negative. And pulmonary pneumonia panel was also done, which was negative. And the galactomannan values, LDH, and the D-dimer values were all within normal limits. But she was managed in MDICU with injection piperacillin and tazobactam, and she was started on IV steroids, injection hydrocortisone, 100 mg IV TDS. After starting the steroids, she showed significant clinical improvement, and her oxygen requirement has come down, and she started to maintain saturation in room air. So we did a CT test on 12th July, and it shows diffuse ground glass opacities with subpleural reticulations. And a cardiology variation was also done, which was normal. And we did a baseline PFT before discharge, which was more in favor of a small airway involvement. And she was clinically better with the steroids and all other treatment measures, and she was discharged with steroids and PCP prophylaxis. And 2 weeks after discharge, she presented to us for routine review, and her X-ray showed significant clearance, and hence steroids were stopped, and she was advised to continue the inhalers only.
Okay, we'll stop. Vimalra sir, we are not making any sense. So if you can just show us this images.
Sure, 1 second. So this is the CT scan on the 12th of July, what we are seeing here. Let me just start with the mediastinal windows, and we can see these chunky lymph nodes. Even at that point in time, there are prominent lymph nodes in the right paratracheal, right hilar, and some in subcarinal distribution. And as we go into the bases, there are small pleural effusions with atelectatic changes. When we look at the lung parenchyma as such, what we are seeing are these patchy areas of ground glass opacities, very randomly distributed. What is interesting are these subpleural areas of linear band-like opacities that we can see across here with extreme sparing of the subpleural aspect. Multifocal areas, mild traction dilatation of bronchi. There is some mosaicism, not a major mosaicism, but mild mosaicism. So overall, this is looking like a post-infective change more than anything. There are multifocal patchy areas of infection. This is looking post-infective. Some of these can represent a NSIP pattern of interstitial changes, early changes where you can see across here. So at this point in time, I would have said post-infective with some NSIP pattern of interstitial changes that we are seeing, basically saying this is very, very non-specific at this point in time. Not much in terms of fibrosis.
Do we have that representative CT scan which she's saying there was improvement with steroids, sir?
I don't have that, no.
Okay, fine.
This is the 12th one, which I think is
Post
fast-
steroids, yeah.
Yeah.
Okay, fine. Sure.
Wouldn't this look like what you saw in COVID, Vima?
So these ones, specific areas would look like that, something like this. And this is what COVID looked like in post-infective, in post-recovery phases of COVID.
Sure.
These things would look like that. So that's why post-infective viral changes, but it's just too extensive for it to be simple COVID when we saw, because there's a lot of distribution even going all the way to the upper lobes also.
Okay. No, those bands, subpleural bands, the response to steroid. I mean, I would have thought this was a recovering bad COVID pneumonia.
Yeah,
until
it's
proven otherwise.
recovering infection. What
Yeah.
kind of infection is
Sure.
uncertain.
Yeah, sure. So we will move ahead. So this is where we left.
Okay. 1 week after the discharge, the steroids were stopped, and 1 week later, she presented again with complaints of high-grade fever associated with cough with minimal respiration, and she had severe myalgia and tiredness, and she was again hypoxic with a saturation of 67% in room air, and she was admitted in our respiratory HDO and was initiated on HFNC and intermittent NAV due to worsening O2 requirement. And on auscultation, there were bilateral crackles just like in the last admission, and again the
Can we
evaluations,
start doing it?
the D-dimer value was negative.
Yeah.
The D-dimer was negative, and the
ना
blood
ना
and
मैं ये
sputum
कह रही
were sent
थी
for culture and sensitivity.
आलू छीलना शुरू करो तुम.
Richa, you'll have to mute yourself, Richa.
Oops.
No worries.
She was started on Ceftriaxone, doxycycline, and against injection mediated prednisone 80 mg IV TDS. And her chest X-ray on 7th August showed recurrence of diffuse opacities. And the pyrexia workup was again negative, like expert PCR, dengue NS1, leptospira, and the respiratory panel was also negative. After starting the steroids, she showed significant clinical and symptomatic improvement. After taking the rheumatology opinion, she was evaluated for CTD, connective tissue diseases, ANA profile, the rheumatoid factor and anti-CCP were done, which were within normal limits, and the myositis panel was also done, which was again negative. And the vasculitis workup, including anti-PR3 and anti-MP antibodies, were done, which was again negative. And the immunodeficiency workup was also done after taking infectious disease specialist opinion. And the CD4 and CD8 counts were towards the lower limit of normal, and the serum immunoglobulin levels were within normal limits. And we did a repeat CT test on 12th August once she became better. And with the CT findings, we decided to proceed with rigid bronchoscopy plus cryobiopsy and linear EVAS. And we did an advanced PFT just before the procedure. And it was suggestive of a restrictive kind of disease with reduced DLC and VA. And VA-TSC ratio was normal and KCO was reduced, suggestive of an ILD-like picture. And we proceeded with the bronchoscopy and cryobiopsy. Bile was taken from right upper lobe, middle lobe, and lower lobe. EBS was done, and FNAC and FNAB taken from station 7 and station 4R. And the transbronchial lung cryobiopsy was taken with cryoprom from right lower lobe anterior basal, lateral basal, and right middle lobe lateral segment under fluoroscopy guidance.
Yeah. Vimalraj sir, once you show that, I will show the pathology slides.
I'm trying to get that, though. That image is not working. You may have to.
Okay. Then I will just show the pathology slides. No problem. Where are the pathology? You didn't put it here, or is it there? Sneha?
Ma'am, I have sent the pathology image to your mail ID, ma'am.
No, it was not in the PPT, huh?
No, ma'am.
Okay. Fine. Oh, God.
I have resent the pathology studies to mail ID now, ma'am.
That's fine. I'll manage. Don't worry. Yeah, Ritu madam.
Yeah. Okay, so we have a very nice biopsy from the lung which has been taken. And in this low power, what we can appreciate is that there are some emphysematous dilatation of the air spaces which can be seen. Apart from that, the interstitium is looking is thin. There's not much of interstitial inflammation. But what is distinctly seen in the next image is the presence of the intraluminal. In the next image, we can see that there is the presence of these intraluminal plugs of loose fibrinoid material which are forming kind of granulation tissue. So this is the obliterative bronchiolitis, obliterative alveolitis kind of a picture of organizing pneumonia which can be appreciated. And there is some amount of adventitial edema also around the small vessels which are there. And apart from that, the inflammation is not so remarkable. This kind of a picture where everything, so this is a high power showing the same. There is mild surrounding this, and now at this power, we can appreciate the mild interstitial inflammation. But the predominant picture is that of the organizing plugs of loose myxoid material which are blocking the alveolar spaces. And so organizing pneumonia is the predominant appearance here. Considering that all the parameters which are proven to be negative, I would like to keep AFOP, acute fibrinous organizing pneumonia, in the list of differential diagnosis, which I will make.
Okay. Vimal Raj sir, any luck?
Just 1 minute. If you continue with your discussion, I'll
Yeah,
share.
sure. Share the screen and share.
Would you be able to just recap that history, Sneha? What exactly had happened? The steroids, you just discharged her on prednisolone, right? 40 milligram a day?
Sir, after second admission, after this biopsy picture, which was suggestive for organizing pneumonia, she was discharged with prednisolone 40 mg OD. And she came for review after 2 weeks.
Okay. And the hospital
during the
treatment
course
was
in
systemic steroid, right? In the hospital, you gave her parenteral steroid.
she was treated IV medial prednisolone 8 mg IV TDS, which was later tapered to 40 mg BD, and then tapered to oral steroid 40 mg OD prednisolone. And she was discharged with prednisolone 40 mg OD. And she has now completed 6 weeks of prednisolone 40 mg.
Okay.
I have also sent the biopsy slides to PG Chandigarh for a second opinion, because we had a doubt whether it is actually organizing pneumonia or are we missing something else.
Would you, Ritu, call this a very dense inflammatory infiltrate or a reasonable, a moderate inflammatory infiltrate?
I would put it down as mild to moderate, because the predominant picture is the organizing pattern, and the inflammation is very less. But the airway spaces being dilated, that is a little unexpected finding over here in this patient. I don't know why she's at one point there was some anthragotic pigment also. So I was wondering if she has any exposure of that sort.
I can share the images.
Sure, I will stop sharing. So basically this CT scan was taken after steroids, right?
Yeah, so we've got 2 CT scans now. The one on the right-hand side of the screen is from the July time, and this is from September. And what you can see is that there has been a dramatic recovery of the parenchymal changes that you can see. Significant improvement. There remains these focal areas of these parallel reticular bands, which is what we were talking about, which we've seen in post-COVID, but we've also seen in some of the other infective cases, viral infections, which have resolved in there. So significant improvement. Still these reticular bands as resolving changes you can see across in both the lungs, patchy ground glass changes in the upper lobes. All of this is fitting in with organizing pneumonia, which is recovered, but something of a viral background needs to be considered within this.
Here also said there is a peripheral sparing, no?
Yes, subpleural extreme sparing is there.
But there is definitely improvement, yeah.
Yeah.
So I think there is only one last slide which I will show.
In the current admissions, Neha, you didn't get a scan done, right?
So the last admission, she was discharged with 14 GOD, and now she's on a follow-up, and we are to repeat the CT just after 2 weeks.
Okay, so that admission you just managed on X-rays by virtue of the previous admission response.
Yes, sir.
When was the biopsy taken? Which CT scan biopsy represents Sneha? July or September?
Ma'am, Julie.
July. Okay, fine. So you people did biopsy and then he was started on steroids, and now after that you people did a CT scan which is showing resolution, and you planning to do PFT, right?
Yes, ma'am.
Okay. These are the questions for the panel. Any further workup is required? Currently on steroids, should we continue that, or any steroid sparing agents are required? And I will stop sharing. Please stay.
Dr. Smita, may I come in?
Yeah, please.
Yeah, so I could not comment on the first CT. There was somebody came to meet me. So on the first CT, I agree with Dr. Vimal Raj that it is a pattern of, we can call it NSIP, OP or OP. But it very typically looks like what we saw a lot in the recovering phase of COVID. So it indeed looks like a recovering viral pneumonia, because those parenchymal bands and subpleural lines, those were very typically seen with post-viral recovery. And because we saw so many viral pneumonias together, did we realize that this is the typical pattern? So that's why it came to notice during COVID. It may not be specific for COVID. The routine organizing pneumonia will have a little different morphology on CT. There'll be more of patchy consolidation, less of subpleural lines. It might be more extensive, more peripheral and peribronchial. So I don't think that it is a routine OP which occurs with CTD or as part of COP or even drug-induced lung injury. I would just like to ask Dr. Ritu that whether the biopsy also shows features of organizing DAD. Like, does it look like the proliferative phase with a lot of type 2 pneumocyte hyperplasia, some amount of desquamation? Because AFOP, okay. So it doesn't look like organizing DAD.
Yeah, there's no proliferation as in here. Even to call it as cellular NSIP, the inflammation is, as Dr. Sujit had suggested, to suggest of cellular phase of NSIP also the inflammation is less. My thing of the emphysematous dilatation of the air space is something which is more troubling me. Why is that happening?
But there are no lymphoid follicles to suggest CTD?
No, there are no lymphoid follicles, none at all.
The biopsy was of a good size, so I don't think they're missing those, because CTD would be a differential. Idiopathic NSIP doesn't look like, you're right, ma'am. A lot of OP is there, and it will go more with OP with some amount of, as you said, acute fibrinous exudate or acute fibrinous appearance of the thickened septa, because the septa were indeed thickened, but they were not very cellular. So yes, so it might be a recovering phase of an acute viral pneumonia. That's what I would say. And there, I would say that a short course of steroids works well. So maybe in the next 6 to 8 weeks, the steroids can be tapered and stopped. And the monitoring has to be clinical. We don't need to go for 6 to 9 months of therapy. Only if it recurs will we go for steroid sparing agent. Otherwise, there is no need.
Sure. Murli Mohan sir or Rajan sir.
So this is probably a cryptogenic organizing pneumonia, recurrent. I think if he's stable on steroid, probably the taper of steroid should be a little slower, Sneha. I'm assuming, Sneha, your autoimmune workup is fully negative.
Yes, sir.
ANA blots and everything, myositis profile. Yeah. So this is probably triggered by a viral infection, and it's just continuing, it's a slow, persistent response to that viral infection. So you try and just go along with very slow taper, maybe 5 milligrams every fortnight, watching very closely before considering an alternative immunosuppressant. Murli?
Yeah, I completely agree with everything Sejal and you have said. If I had to put a label on it, post-infective AFOP and taper steroids, certainly no role for other immunomodulators, right? But certainly to be considered if there is a, and maybe the course of steroid to dampen it. This is why
Your voice is breaking, sir.
I'm so sorry. So I'm just saying that post-infective, if, let me summarize. Yes, I agree with Sejal.
I can't still hear. Okay.
I agree with everything Sejal said.
Better.
Yeah. Let me log out and call back.
Sure. So, anybody left who wants to say something, or we will move on to third case?
Yeah.
And sir will tell when he's ready. I think Sharda, are you okay with that? Did you get the answer which you wanted? Sharda, sorry,
Okay,
Sneha.
ma'am.
Sneha, sir is telling
ma'am.
that taper of the steroids, the diagnosis, both of them agreed that it looks like cryptogenic organizing pneumonia, which you people also had diagnosed, and slowly steroids. And Sajal said you may not need 6 to 9 months of treatment, and maybe 3 months might be sufficient. You have already done 1 month, so let us see.
Okay, ma'am. Thank you, ma'am.
Thank you. Thank you for presenting. I will move on to Shobha Madam's case, which I only will be presenting. And sorry if I could not answer many questions. I will try to answer whatever I know. So this is a 47 years old man who is resident of Kollam, and he is a KSRTC employee, just inspector in that. He presented with shortness of breath for 7 months and dry cough for 7 months. He presented in July 2024. He didn't have any symptoms of CTD. He was post-COVID twice, 20 and 21. And he has OSA also, for which he was treated with CPAP. He has history of diesel fume exposure at workplace, history of exposure to lovebirds for 15 years before, was exposed only for a year and was asymptomatic that time. He's not a smoker, not even anything. He had clubbing grade 2 and right-sided crepitation present when he came to us. This was his X-ray, which I'll just skip. And pulmonary function test was suggestive of FVC of 60%, DLC of 67%. He walked 360 meters and desaturated to 87%, but he had dyspnea box scale of 1 only. RV by TLC was 32. His pulmonary hypertension was negative on echo. These are his labs, and his CTD markers were predominantly negative. He had borderline elevated HB, I would say, and everything else was normal. ABG was mild hypoxic and mild hypercapnic. That's it. This is his myositis profile. Mithun, anything you want to say?
This looks normal only, negative.
Everything is negative. Yeah. So I will stop sharing here, and Vimalraj sir, if you can just show the CT, and then we will go for biopsy.
So I have this CT scan of this gentleman. So you're seeing the mediastinal as well as the lung windows. Let's quickly look at the mediastinal windows first. small volume lymph nodes, plenty of small volume lymph nodes, not significant too much. Slightly prominent pulmonary artery and the right ventricle. So maybe looking at the echo might be useful. The ratio wise, the pulmonary artery is not dilated. Now, when we look at the lung parenchyma, I'll just start at the bottom, and what you're seeing are these diffuse interstitial changes, brown glass, traction dilatation of bronchi with some coalescing and cyst formation, extending bronchocentric, going all the way out to the periphery. And as we come up, you start to see these subpleural cystic changes. And as we come up here, you can see these along the anterior aspect, multifocal areas of early honeycombing that is getting formed in these areas. So this is something what we would call as a four-corner sign, where we are able to see right upper, left upper parenchymal changes and bilateral lower lobe parenchymal changes. So findings are those of fibrotic interstitial lung disease. The pattern is, it's looking more like a CTD, which is going towards a UIP pattern. But at this stage, it's a NSIP, which is fibrotic. But this would be usually what we would see with exuberant honeycombing in the later stages. So UIP, fibrotic NSIP, but CTD ILD is what I would have thought this as.
Yeah, you made it so clear. I'll just go to the, I think there was a reason that madam did a biopsy, because not sure presently, but she decided to do biopsy because he was young. Yeah, 47. That is why they did biopsy, I remember. So I'll just go through the biopsy. Madam, Ritu madam?
Yeah, hello.
Yeah.
So the biopsy is showing at the low power. We can see that there is the central part which is highlighted is showing a complete alveolar filling. And towards the periphery, we can see at the low power that there is some amount of cystic change which can be seen. On the one which is showing 10x, so there is some amount of mucostasis. There are inflammatory infiltrates, there is interstitial widening, there is fibrosis which is occurring in distortion of alveolar architecture. And when we take it under the further 40x magnification, I am not so convinced of calling them as fibroblastic foci, but definitely there is some amount of organization which is occurring, and just surrounded by inflammation. So with this kind of a picture, I would see, for me, when I look at a biopsy, I want four patterns. One is an abrupt transition between a normal and an abnormal to call it a UIP. I'm not seeing that here. I'm seeing the entire parenchyma being involved uniformly. Then second thing is that I'm seeing honeycombing changes which are lined by some metaplastic cells. So that is one towards which is there. And the third is the fibroblastic foci, which at this power I'm not able to appreciate. So I would, but there are no other features which are ruling out a UIP like pattern by in terms of any lymphoid follicle or OP as they have seen it, but I'm not able to see it at this power. So considering this microcystic change, mucostasis, transitional metaplasia, and this kind of cellularity, cellular infiltrate which is there. My first differential would be a mixed cellular and fibrotic pattern, and but keeping the microscopic cystic change over here, but the lack of lymphoid follicles, I would not be able to rule out a CTD ILD on this. And this is as far as I would go. I wouldn't label it as a UIP as of now immediately.
Okay. So both the radiology and pathology feels that CTD ILD cannot be ruled out. And the reason madam has put it is what is the consensus ILD diagnosis, degree of diagnostic confidence, any differential and any management plan. Anybody wants to take? Sajal, you there?
So are there any autoimmune features, Asmita, clinically on this lady?
I think no. 1 second. That is what I showed because she specifically
Nothing. Yeah,
mentioned
I
many.
remember this one.
Many.
And she's 47 years old, right?
Yeah, 47. That is the reason.
47. She's too young for other issues. I think clinically, pathologically, there are some suggestions of you probably label her as an interstitial pneumonia with autoimmune features, but that's really unclassifiable right now. Even with this biopsy, you can't have a confident, it's a low confidence diagnosis in my opinion. And so we aren't sure really what is happening here, except that she has significant interstitial disease. What's her vital capacity, DLCO like, Asmita?
60%. 60%.
Right.
I'll just show that table again. So,
The saturation was dropping significantly. She's clubbed also, right?
he's
He's
yeah,
clubbed.
he was.
He's
Yeah, you
dropping,
can see now. Yeah.
he's dropping significantly. DLCO is quite well preserved, actually, considering the vital capacity has gone down so much. Is he obese?
Yes, significantly obese. Patient is non-case of obstructive sleep apnea and on CPAP.
So probably that's why the vital capacity is a bit low. I'm just wondering.
Yeah, it's adding up to the
But
interstitial obese,
it doesn't explain the desaturation, right? So he's definitely got an interstitial lung disease. He doesn't have pulmonary hypertension. I would find it very hard. Even with this cryobiopsy, we are not, even though it's a good biopsy, we aren't much wiser. I don't know what Sejal or Murli has to say on this.
Yeah. Please go ahead, Sejal or Murli sir. Yeah, Sejal, go ahead.
You're muted,
Middle,
Sejal.
so I missed a lot. Yeah, I got some resident coming in, so I missed a few things, so I'm not really able to comment.
What do you want to see? CT?
Can I just get one or two things from Dr. Ritu? What did she see in the biopsy?
Yeah, sure. I'll go through that. You want me to share it again?
No, I just want to ask what are the features on the histology?
Yeah,
key
so
features.
on the histology, the key features would be architectural distortion, alveolar filling, microcystic change. I am not so convinced about fibroblastic foci proliferation, and I'm not seeing lymphoid follicles. So it's my the thing would be between whether we are dealing with, and there is cellular inflammation also. So whether we are dealing with NSIP, which is progressing, or UIP, I don't have the abrupt transition between the abnormal and the normal lung. So I can't call it as UIP, even though the biopsy is very, very nice. I can't call it that. And I can't see the fibroblastic foci, which are typically, dome shaped, and you're seeing it at the advancing edge of fibrosis. At this power, I could not appreciate it. So for that basis,
Ma'am, how much, how frequent were the fibroblastic foci? Were there too many or just one odd?
I think they've labeled it as fibroblastic foci, but I'm not really so convinced on seeing them. So with this, even if we take it as fibroblastic foci, also we would have two features out of the four. That means fibroblastic foci and honeycombing. So with that also, it would go into probable histopathologically, it would go into probable UIP pattern.
Yes, ma'am.
See,
So,
radiologically, it is one of those classical. If you give it some time, it's going to be an CTD with a UIP pattern with exuberant honeycombing, four corner signs, all of these getting established. So it's in that transition. So that's why I think Dr. Ritu is also similar to us. We are not sure how far down that transition it has gone.
But no peribronchiolar infiltrates, lymphocytic, or giant cells, ill-formed granulomas, those are not there. HP like.
Not at this power. I couldn't appreciate it at this power.
And at the time when the biopsy was done, there was nothing to suggest acute exacerbation clinically.
I think Dr. Asmita.
Yeah, I believe he has a very, very bad phase after biopsy. He suffered a lot. That's what I heard. But anyway, he was fine afterwards. Like initial few days post biopsy, he was sick. So I'm not sure.
But at the time, before the
at the time
biopsy,
of
there was
biopsy,
no.
he was not sick. Yeah.
Okay, so the kind of ground glassing we saw along with the pattern of honeycombing, I would agree with Dr. Vimal that a CTD ILD fits best, although we didn't get things which were pathognomonic on the biopsy. So HP, we don't see anything supportive on the biopsy, although history
No,
of
he
lower body
didn't
exposure
have. No,
was.
no, no. That was 15 years before and for 1 year. I think
Okay.
that was a tricky
Okay.
history we can ignore.
Okay,
Yeah.
okay. Then it best fits with CTD ILD, where the CTD still remains undefined.
So should we
But
agree
it'll
with
be a
Sujit Rajan sir's diagnosis of ILD with autoimmune features?
yes, I think so.
IPEF.
Because
Yeah.
it'll still be low confidence, but
Yeah.
yes, that is the best thing that fits here.
Murli Mohan sir.
Yeah, I would agree, except I'd go to moderate confidence. I think that CT is so strongly suggestive of, the pattern fits with a CTD-ILD, but we just don't have the clinical features. So I would just wait, repeat these things. He's already showing evidence of fibrosis, start an antifibrotic, and, review after 3 and 6 months.
Everybody agrees about antifibrotic starting, sir?
I'm not too fast on antifibrotics in these patients until I see Murli. I would see a drop in lung function, progression of fibrosis. We haven't seen any of that, right? We don't have serial scans. We don't have serial lung function either, Smita, right?
Yeah.
No, I agree upon that.
But I agree
still
he's
think
far
I would
out.
start
I
out.
agree he's far out in the disease.
Yeah, your criteria is too strict. I am one person who believes hit hard, hit fast, and your criteria is until unless we have progression from the day of PFT, we have to document the definition.
Ma'am,
I
that
get it,
hit fast, it goes more for immunosuppression rather than antifibrotics.
Yeah.
Sure.
So it is rather that we should hit hard and hit fast with immunosuppression first, and then see
Yes.
even a hint of progression on that,
Yeah.
we can go ahead with antifibrotics.
Sequentially.
Like we can, yes, we can have, at least we will know whether the patient is responding to immunosuppression for
Why not
some period of
MMF?
time
Now,
or not.
why not? You want to see
Yes, it may be.
rituximab or something?
No.
I do not go with Ritux, no,
Sure.
not at all with Ritux, but mycophenolate will be a good choice, yes.
Okay.
I would agree with immunosuppression, but I think this guy is going to need his antibiotics soon. I
Yeah.
wouldn't wait too long. Follow him up carefully. Our general experience has been, when you see so much and it's progressing fairly rapidly, people go downhill pretty fast. So I'd review him very quickly.
Correct.
But I'd agree, there's no harm in giving him the immunosuppressant and deciding on starting the antifibrotic later. I think you're going to have to do it. And my temptation would be to do what Dr. Asmita said, start the antifibrotic and this at the same time.
Right. So I would just probably maybe agree with Murli on the fact that he's likely to need an antifibrotic, start the conversation, hit hard with immunomodulation, and the whole thing is when that conversation on the antifibrotic starts, it's, that's a lifelong drug, right? It's a big decision. So when we talk to our patients, we have to tell them that this is going to be for life. So we just want to be, and it's a young man. So
I agree. No, I was just telling.
But I hear the other experts, and I think.
So I'm going to play devil's advocate here and say, why does it have to be lifelong? If you're able to get very good evidence that you've reversed the reversible part of it, you gradually withdraw the antifibrotic. There is some evidence that, interruptions in treatment don't change the effectiveness of the antifibrotic. So, you're not completely committed to it.
Sure. So that's an interesting new aspect to the conversation. I must keep in mind, I think. But you're right. I think in COVID, we did have that window to talk about stopping antifibrotics. And right now it's intolerance or long-term stability. And you're right, we have one patient who's stable for 8 years on it, and now I'm wondering whether it was the right decision. She isn't progressing. Pathology was UIP. So we can go wrong also in the decisions, you're right, or we may want to, revisit.
Sure, we'll move on to last case if we are
Yes.
okay. Yeah.
Yes. So this is, out of 4 cases, 3 had PATH, but my cases are more like the situation in India where the registry had only 7% of PATH. And so this patient doesn't have PATH, and I don't think he's going to have PATH. He's an elderly man, 3 children, mild smoker, retired businessman in Kolkata. And he's largely homebound since 2017, moves around in his house, ischemic heart disease, stable, BPH, and a mild anxiety. He's basically averse to traveling, doesn't want to travel. He's very happy within his house. He didn't get vaccinated for COVID also. Really doesn't step out much. He got hospitalized in Kolkata with type 1 respiratory failure between 26 July to 2nd August. That's about 2 months ago exactly. Cough and fever. It began with cough and fever in mid-July, and he got hospitalized in an ICU there, treated with IV steroids, antivirals, antibiotics. Oral steroids tapered and omitted 2 weeks ago. No autoimmune symptoms. His appetite has dropped since 3 months, and he has an 8-kilo weight loss. He has a fear of walking too much. When we mentioned he should get mobilized and move around because of his back pain. He has lumbar canal stenosis. His whole autoimmune workup is negative. ESR is 28. Ferritin, this is just recently done again, the autoimmune workup. Ferritin 275, hemoglobin, white cell count, myositis blot also negative. His current situation, if you can just keep the last slide, Asmita, is he remains weak. He needs help to bathe now. But he takes 8 or 10 rounds in his large living room every day. He desaturates to not less than 90-92%. He had a past history, as I said, of lumbar canal stenosis. He needed nerve blocks in June and bilateral herniorrhaphies, nothing else. And so that's the history. And so we have, I think, 2 scans or 3, Vimal. Yeah. So one was when he had, it was long ago during COVID time, I think.
Yeah, so very interesting. So this is one of those where we almost have a normal scan. So this is from year 2020. So
Correct.
December 2020, just to get an idea of how his lungs looked.
I think this was a typical, sorry to interrupt you, but this was a scan done because he had a mild fever at home with COVID, just got a scan done. Yeah.
Yeah. So non-specific atelectatic changes in the lingula and the left lower lobe. Otherwise, nothing very great. Then this is the acute admission point where you can see extensive multifocal patchy areas of ground glass. He's not been able to hold his breath that well, and that's why you're seeing a lot of different mosaicism patterns across here, but different multifocal areas of ground glass consolidation in the lungs bilaterally, and this was in July 2024. Now, if I fast forward to more recent, and what you can see here, a lot of those ground glass have all gone now, but they have left behind reticular changes. There are these fine reticular changes throughout his lungs, more of a peripheral distribution of these. The bronchi are also dilated a little bit as we go down to the extreme lung bases. There's some traction dilatation of bronchi. Not seeing any mosaicism right now. And most of the ground glass seems to have resolved in here. If you see again, this is one of the things where even this patient has a fissure which has got a little bit nodular outline to it that we can see, but not very convincing in terms of sarcoid. I'm not raising sarcoid. I'm just showing that the fissure just looks a little nodular. And no honeycombing. We are not seeing any nodules or mass lesions to explain his weight loss as such. So if we just put all of these together and we see what has happened, where it was absolutely normal to begin with, a lot of ground glass changes, and now it's gone into interstitial changes where early fibrosis has started to settle in. This pattern is very indeterminate. It's not a UIP. If anything is very diffuse, that kind of puts me more towards an NSIP pattern, which is getting better from before. But otherwise, truly indeterminate in what we are seeing at this stage.
Can I ask you something, Vimalraj sir? Was the 2020 CT scan, the subpleural thing, was early ILD or?
No, I think that was just the lingular changes where next to the heart, you often get these atelectatic changes next to the heart and diaphragm. So
What's
those
happening in
changes,
subpleural areas? Nothing, huh?
not at that time, nothing much, no. Not even, this is poor breath hold towards the lung basis, but as we go up, this is normal, nothing. These bands, again, as we were talking,
COVID, yeah.
we see these bands actually in a lot of patients. They became very common after COVID, but we do see these in a lot of patients.
Sure.
And some of these are what may be called as ILAs, but because if you see now, those bands are almost gone. Those bands are not there in the acute phase. So they are just on and off bands.
Dr. Vimal, the second CT is of July 2024.
That's
Yes.
right. That's
Yeah.
right.
Okay.
And the
That was
last
the
is
initial
September.
acute respiratory failure.
last is September. Fine.
Yeah.
The
Okay.
last is about 2 weeks ago. I had got Bhavin to review these scans, and he thought the last one was suggestive of, he signed off on the last one as probable UIP. Now, I mean, this gentleman is not going to agree to a biopsy. So I got his full autoimmune workup repeated. They had done it in the hospital in Kolkata. I asked them to repeat it when we came for a second opinion. The whole thing is negative. There's nothing on the serology blood work to suggest autoimmune disease. So, and off steroids now for 2 weeks. When I spoke to his son, he said there's not much change after stopping steroids either. So I'm wondering, A, should we push for a biopsy at all? He's 77 years old. I don't think he will agree. And whether to just start antifibrotics, probable UIP in a 77-year-old, I don't. I'd really like to know what Sejal and Murli would do here.
I think it is very typically post-ARDS fibrosis. So we keep on seeing these cases, and we saw a lot in COVID also that viral pneumonia-induced DAD or ARDS occurs. And then in some patients, it rapidly evolves into a fibrotic lung disease. Now, that fibrotic lung disease is mostly stable, but sometimes it is progressive. And in the initial part of this illness, when the chronic phase has begun, it will be responsive to immunosuppression or a low dose of steroid.
Right.
And after some time, it will either stabilize or it will start progressing. So it is difficult to really say in whom it will progress. But we did some genetic analysis during the COVID times. We presented it in a research letter in IJMR, where we looked at the mucin 5B RS35905950 mutation, 35705950 mutation, which is the usual promoter SNP associated with IPF. So there because the numbers were small, we didn't get a statistically significant result, but the trend was towards having a higher prevalence of this mucin 5B SNP in those who developed this post-COVID diffuse parenchymal lung abnormalities with symptomatic post-COVID DLD, we can say. So maybe some genetic factors or other environmental factors, maybe history of smoking, all these things might be predisposing a patient to developing this kind of a post-ARDS or post-DAD fibrotic interstitial lung disease. So in this case, I would say that we can start with a low dose of steroid, which can be given for anywhere between 6 to 12 weeks, and then stop it. And if the patient is much improved symptomatically and physiologically, we can observe. But again, if there is even a slightest hint that the patient is going down symptomatically, is not improving, is not feeling good with his breath, at this age, we can start antifibrotics and continue it just as we do in IPF. But maybe a little window to just explore whether we can do without antifibrotics. Maybe a short window of 3 months or something where we could explore it. But
I think he's so much better, Sejal. I mean, he's received now close to 6 weeks of steroids. when they stopped it after admission. So total admission to stoppage mid-September, or a little before mid-September, it was stopped. So we are 2 weeks off steroids. I found that genetic test very interesting. So the MUC5B SNP is what you're saying we should test for?
Yes. See, it is not pathognomonic for these patients, because in our
Right,
general population, the prevalence is about 10%.
Yeah.
Yes.
So it doesn't give you an answer, but if as part of a study, we found that the proportion of subjects having this mutation amongst
Yeah.
those who did develop this kind of a lung disease after COVID was higher, numerically higher. So it is having some bearing, just like it does with IPF. It has
But-
some bearing for the tendency of the lung to develop a fibrotic lung disease.
Okay, got
So
it.
We've shown the
if you feel that the
same
patient
with,
has improved a lot, then you can as well observe, sir, for maybe 3 to 4
So
months.
I'm finding it hard to even get a lung function done on him, but I'm trying to now get him to the hospital to do a baseline lung function, and then
Yeah,
yeah.
and maybe he can just keep on checking a post-exertional saturation,
Yeah,
even at his house.
correct.
A 1-minute test or just a hall walk resat
Hall
test.
walk is down to 90, 92, not below that. He's not
Yeah,
going
so
below.
he might do it every 2
Keep a
weeks,
watch on
and
that.
the
Yeah.
moment it starts going down, he can present to the hospital.
Sure. And we can reintroduce steroids and revisit this whole thing.
Yes, in some cases, we did a study, the Colster trial, to look at steroids in post-COVID DLD. And in
Right.
some cases, we needed to continue the steroids beyond the usual period of 6 weeks. Sometimes we had to raise the dose also.
Yeah.
So in some cases, so 10 milligram per day for 6 weeks was good enough.
Sure.
But in some cases, we did need to continue it for 3 or even up to 6 months at a very low dose, maybe 5 milligrams. So,
I also was looking for an inflammatory arthropathy, if that could be linked to this. So we got the spine MR and the hip pelvic MRI is also reviewed by Bhavin, who's pretty good at bone and joints, as you know, Vimal. And he said sacroiliacs were fine, no evidence of any inflammatory arthropathy in the hips or the spine. So it's all lumbar canal, degenerative lumbar canal stenosis. That was his. Yeah,
so
Murli,
Sujit,
sorry.
what were his symptoms between 2020 and 24?
So very little sedentary lifestyle within his house. He was just moving because COVID. So then he was literally locked in by his family in the house. So just walked. He was quite happy that way. He's happy even that way even now. So it's not changed his life.
No, the reason I'm asking is, he could have progressed even with his UIP, and then he gets an infection which shows up as these extensive ground glass changes. And then when that recovers, he goes back to his older UIP pattern. So this may not, it is certainly possible. I completely agree with what Sergil said. We have seen these post-infective things precipitating lung fibrosis, but we've also seen somebody who you've never known. And that's the typical story.
Correct.
They've had very little
exertion. Like an unmasking.
Then they exacerbate following the infection. So I would have little hesitation in starting an antifibrotic. Very little hesitation. And I don't even know if it's necessary to start his steroids if he's feeling better. He's so limited. My, feeling is the risk-benefit ratio maybe in not restarting the steroids, just waiting and watching. If he deteriorates, start it. If he remains stable, I wouldn't restart it at all.
No, so I've done exactly what you've done. I've suggested that we probably will have to go to antifibrotics. Told him this conversation's been very useful today. Thank you, Asmita, for allowing me to get the case in. And I think we have that antifibrotic on. Watch him. If he deteriorates, we get steroids back on. Yeah. And probably repeat a scan if he really gets worse. But he seems pretty stable. Fortnight off steroids now.
And if cost is not an issue, I would suggest you get the genetic study done.
Yes,
Somebody on a fibrosis panel. I think it's very interesting. We need to start.
Totally. I will suggest that to them as well, because his family can do a lot of things, even though the man is ensconced in his house. The sons are traveling from Kolkata to Mumbai.
I have actually 2 questions to ask now, because Sir has brought out this and Sajal has brought out this MUC5B gene and all. So it won't able to differentiate whether the DLD is secondary to IPF or secondary to COVID fibrosis, right? It will just tell that patient had tendency towards fibrosis, right, Sajal?
Yes. So even in young patients, we saw that those who were positive for this mutation, they might be considered to have a higher tendency to develop these post-COVID ILAs or even ILD if it is symptomatic. But it does not differentiate between what types of
Yes.
fibrosis. And see, this has been found to be associated with hypersensitivity pneumonitis also, fibrotic HP,
Yeah.
but not with sarcoid.
Not with
So
sarcoid.
sarcoid may be a different spectrum. Fibrotic sarcoid may be very different. The pathogenesis, as we know, is different from what we see in IPF or even HP.
Yeah.
So
So the
it
same
has a bearing in these set of fibrotic lung diseases, like say post-viral or post-EAD, ILD or chronic HP and IPF, but not in something like sarcoid.
Yeah, and one question is from the participant who is Dr. Kiran, who is a very good friend of mine who practices in Trivandrum. He has asked, particularly Rajan sir, that the elderly gentleman who is confined to his house, is there something in the house which he is constantly exposed to? Or is it a drug for anxiety, maybe drug-induced pulmonary injury or mold-induced inhalational fibrosis? That is what he's told.
So I don't think we looked at triggers in the house because the scan, I mean, he's been at home for years. The scan was not suggestive of HP. So we didn't look at extraneous triggers. As far as he's on no drug for anxiety except not even a sedative. So he's not on anything, from that perspective.
sedate by himself.
Yeah, he's sedate by himself.
Yeah. And this COVID happened somewhere in 2020. Now, how can we attribute that COVID is causing problem, that loss of weight and everything happened just last 1 year? So,
Yeah.
aren't we too much imagining, sir, here that COVID, which was going on, and then fibrosis came and
He was never sick all these years, really.
Yeah.
This scan we just pulled out. I mean, there was a scan available. The weight loss could also be because of the stress and anxiety of this whole thing, I think that's more likely.
Or maybe hypoxia. He's not able to
That's
eat.
right.
Yeah. Muscle wasting.
Yeah, muscle wasting is there. So he's working. I've told him to go good rehab and suggested an antifibrotic, but I will go back to them saying they can wait on that as well if he's stable for some more time.
I think that's it.
Thank you.
We
Great.
have come to the end of it, and we will have after 2 weeks, that will be
11th October.
Yeah, 11th October. 11th October. Sure. So thank you so much, all the people who have joined from that side and all our experts over here. It was really fruitful discussion, and I hope it helped all of us to treat our patients better. Manish, can we make it offline, please? Manish? Yeah, thank you. Yeah, it was great.